Okay, now the final speaker for this session is Mr. Horst Thiele, another local. Horst is the senior pharmacist with the acute or post-acute care service in the hospital and the home service in Northern Sydney Local Health District. That's based at Royal North Shore Hospital. He's a member of the New South Wales HITH Working Group and the SHPA's Primary Care and Transitions of Care Committee. I've been fortunate enough to talk with Horst earlier today and by email, and if there's one thing that I've learned from him, he has this very good attribute of being quite honest, and he promises me he is going to be controversial here, so we're looking forward to hearing the controversies as told by Horst.
Thank you, Jason. I didn't tell you that I also ride my bicycle to work every day. So it's not a hint. So first I have to say I have no interests to declare. In contrast to most of the speakers today here, I'm not a specialist infectious diseases clinician, but a generalist pharmacist with an interest in infectious diseases at most. In this, I am actually representative of most clinicians working in New South Wales HITH services, where HITH services care for many other patient groups other than those requiring parenteral antimicrobial treatments. And those referrals constitute about 50% of our referral base for the average New South Wales service. It's great to have such a strong New South Wales HITH representation here today, I think. Our service is one of only a handful of HITH services in New South Wales, and I think indeed Australia, employing a pharmacist exclusively to provide clinical pharmacy services to the HITH service. And the secret is to have it separate from the pharmacy department so you can't be siphoned off. So primary and community health is employing me, not the pharmacy. And our second pharmacist, we have 2 FTEs in HITH, pharmacists. Sorry, just to make you jealous. Continuity in this role for almost 10 years has allowed me to observe and help shape the evolving field of HITH in Northern Sydney and indeed New South Wales. Today, I want to provide a local New South Wales adult HITH perspective on topics already discussed more generally by previous speakers, in fact, more specifically as well. My allocated topic, developing an OPAT service case study with lessons learned, tempted me to use my half an hour to discuss the benefits of integrating the HITH service with other primary and community health services, like community nursing, to provide vulnerable patients using high-risk medicines with the best possible continuity of care, including medication management at discharge from hospital back to the community, a very important topic in my opinion, and by the sounds of it, a topic that resonates with other HITH pharmacists. I was also tempted to discuss the changing nature of the HITH service as a result of a closer alignment with infectious diseases department. So how patient profiles change, how treatment choices change, and how relationships with service providers in primary care, especially GPs, change. This process started 7 years ago for our service and is well worth further analysis. In the end, I decided to focus on a more pharmacy-specific therapeutic conundrum, and I was sure that would dominate the day today, hoping that as the last speaker, I would still be able to make a meaningful contribution. I actually count it now as a blessing that I'm the last speaker, after Mark, John, Tony, and Matt have already elaborated on the topic. So here are the life and times of the ceftazidime infuser. I have thoroughly depersonalized my presentation. Any resemblance to any trading company is purely coincidental. And if I sound facetious at times, I apologize in advance. So, but for the case study first, this is Mrs. JH, a very pleasant 75-year-old lady who lives in an outer suburb in northern Sydney. Her respiratory physician refers her to the HITH service as an outpatient for treatment of infective exacerbation of bronchiectasis, pure hospital avoidance. So she's not an inpatient, she comes straight to us from the community. Her previous medical history include bronchiectasis, COPD, she stopped smoking at the age of 23. She had ablation for AF. She suffers from anxiety and palpitations and from dry eyes. Her medication list is appropriately short, Spiriva Respimat, 2 puffs daily, Symbicort Turbohaler, 2 puffs twice a day. She uses diazepam as needed, and pantoprazole 40 milligrams daily, and has been known to increase that to BD dosing when she gets epigastric pain, which may or may not be related to her anxiety. So a sputum was done on the 8th of January by a private pathology, hence the blurry scanned printout from the private pathology. It's a tazocin-resistant Pseudomonas. A mycobacterial PCR was also done, which was negative. A central line is inserted at a nearby private hospital, which is a common occurrence if the patients are referred from specialists outside the hospital and they find it hard to access interventional radiology at the public hospital. So a single lumen PICC line is inserted at second attempt, depriving our service of the option of using cefepime 3 grams, 2 concurrent infusers for a 6 gram per 24-hour dose, because we only have a single lumen line. In a 3-way phone call between the HITH service, the referring respiratory physician, and the ID doctor, which is our service's standard AMS gatekeeping mechanism for admissions, the ID doctor approves the admission of Mrs. JH to the HITH service for 2 weeks of ceftazidime, 3 grams per 12 hours, 120 mils twice daily infusers. Now, our service did not always use 3-gram 12-hour ceftazidime infusers. Like most HITH services, we use 6-gram and 24-hour infusers, commercially available from Company B. In 2014, the new OPAT chapter in version 15 of the antibiotic TG took many of us by surprise. The list, and you're all very familiar with this, the entry lists ceftazidime having a 5-day fridge stability with then 24 hours at 23 degrees, a 6-gram daily dose given as 12-hour continuous infusions. Very prescriptive. Following the national reference publication, as an obedient HITH service, we changed our local guideline in late 2014. Company B told us at the time that they were developing special cold bags where the infuser was surrounded by 4 ice bricks. Other services in Sydney continue to use the 6-gram over 24-hour infuser, as they continue to be commercially available from Company B and also from Company A. These services, some being CF centers with much higher demand for meropenem and ceftazidime, stated that no treatment failures or adverse drug reactions had been observed, and that therefore there was no need to review current practice and double the cost of treatment. Some literature service, like one of those is in the picture here, attested to that. So we entered a phase of treatment by postcode. The LHD immediately to our north would only accept patients back from our tertiary referral hospital on twice-daily ceftazidime infusers. Whereas the LHDs to our south and to our west would supply 24-hour ceftazidime infusers for patients returning from their hospitals but residing in our LHD and therefore being treated by our HITH nurses. Private hospital referrals added a further layer of complexity. The private health funds would not authorize the higher cost of the BD infusers. So resulting in public patients in our LHD receiving BD ceftazidime infusers, but private patients receiving 24-hour ceftazidime infusers. By late 2015, the situation for our HITH service had become so confusing that the ID department requested that our LHD revert back to 24-hour meropenem and ceftazidime infusers. However, other publications had discussed the stability of third and fourth generation cephalosporins and potential accumulation of degradation products a decade earlier, whilst considering the clinical need for extended infusions in contrast to short infusions to provide effective anti-pseudomonal treatment. And I don't need to elaborate on those conflicting factors. Speakers before me have done that. Except to point out the bad luck of ceftazidime, that it has such a simple side chain, which had previous studies done as a solvent, the pyridine, that's been discussed here all day. So that article of Vianney in 2002 says as early as 20 years ago that ceftazidime, cefepime have common stability issues and neither should be used for 24-hour infusions at temperatures over 25 degrees and that there is this limit of 1.1 milligram per milliliter of pyridine. So around the same time, and we have a habit today of quoting each other, so I shall oblige and do the same. So around the same time of the TG publication, the team around Tony from Gosford, to get it to make the distinction right, Tony from Gosford and not Tony from Westmead, challenged the common misconception about temperature exposure of antibiotic infusers, determining that infusion devices are often exposed to much higher temperatures than those used for stability testing. Unfortunately, the publication in the American Journal took 4 years, and in the meantime, we had that Rumard article which basically said the same thing. Company B notified us that they had abandoned the development of the cooler bag as infusion under cold chain conditions depressed the infusion rate significantly. We had the choice of incomplete dose delivery due to the degradation of the drug at ambient temperature, or an incomplete dose delivery due to residual volume, the latter having the advantage of excluding degradation products, but the disadvantage of unpredictable amounts of residual volume. We opted for a compromise, advising our patients to change the flexible ice packs in the infuser pouches hourly during waking hours for meropenem and ceftazidime infusers, which, according to Tony's research, would lower the infuser temperature by 5 to 10 degrees. We also loaded the meropenem infusers with 4 grams for the standard 3-gram dose. In March 2017, the editors of TG Antibiotic invited feedback on the OPAT chapter, and I provided my views, including that on ceftazidime and meropenem issue, and advised them of the information I had received from Company B of an impending shelf life reduction for ceftazidime infusers. The same month saw a very informative webinar from Princess Alexandra in Brisbane, Lauren Kazakov, the OPAT pharmacist, advocating a distinction between 12 and 24-hour meropenem infusers depending on patient weight, renal function, and MIC. Important to keep in mind the differences between the meropenem with non-toxic degradation products, pointed out earlier today, compared to ceftazidime and cefepime with unstable C3 substituents. So the proposal from PA is more technical than achievable for most New South Wales HITH services, as it required the determination of an MIC for the meropenem, which we routinely don't do. Indeed, in April 2017, Company B implemented an Australia-wide a global shelf life reduction for ceftazidime infusers, sparked by the review in the UK. We reviewed our need for ceftazidime infusers at that time. We had treated 20 patients from April 16 to April 17 with ceftazidime infusers. Half of them were orthopedic and were easy to substitute, and the other 10 were infective exacerbation of bronchiectasis and generally harder to substitute. And they came from a variety of hospitals. So 2 came from St. Vincent's here, 1 from RPA, 1 from Westmead, and the others were our own. Receiving lots of questions, Company A issues a statement in May 17, confirming its expiry and announcing further studies. It stated in that statement that a pyridine content of 1.5% of the ceftazidime dose, or 138 milligrams, had been measured, and that the allowable range was 2 milligrams to 264 milligrams. So they actually, in that statement, made it sound as if it was a range of pyridine concentration, whereas actually what it was 2 upper limit cutoffs, one from the EMA, from the Europeans, saying 2 milligram is our current cutoff, albeit bear in mind that their 2 milligrams referred to residual solvents, so nothing to do with ceftazidime infusions. It referred to organic, where pyridine was used as a residual solvent, totally different issue. So their cutoff for residual solvents was 2 milligrams, whereas the 264 milligrams was a multiplication of 1.1 milligrams per mil times 240 mils in an infuser. So we have actually two upper limits differing by 2 orders of magnitude, not a range. So then, in June 2017 comes a final statement from Company A. 8 days at 2 to 8 and 24 hours at 25 gives you under 1% of pyridine, which would be 60 milligrams for our standard 6-gram dose. We have now reached a point where literature review and stability testing from 2 companies for the same product have resulted in diametrically opposed conclusions. Informed about Company B's change to ceftazidime, our ID department instructs us in April 2017 to change back to the BD infusers, which we now procure from Company A, as Company B only offers 6 hours at room temperature. We follow the guidance of the National Reference Standard TG, which by now allows a longer infusion time than Company B commercially offers, but Company A still offers an even longer one. So we adopt a pragmatic approach for confusing times. And I think our ID department was not so much thinking about clinical relevance, but rather legal protection in that context. So you can see on the bottom here, the red circle, the 2 to 264 range. It's even written down as a range. It's not a range. There are 2 ceiling levels, different by 2 orders of magnitude. So 7 months pass, and in February 2018, Company B changes the parameters for meropenem continuous infusions, effectively rendering meropenem infusers unusable in HITH, resulting in a disparity for a second drug. So we have 2 companies, same product, different decisions, déjà vu, prompting new questions from us. I called the TGA. Of course, they are only responsible for the production facilities and don't want to know anything about that. In fact, and I'm not sure whether that should be recorded, but from a senior person in the TGA said to me, if that product is commercially available, you can buy it. The annual Ministry of Health organized HITH forum in March last year allowed me to network and to collect information from other services, and I also asked the New South Wales Therapeutic Advisory Group to put out these questions in March 2018. What are you doing? Please help. We got a very detailed, very good answer from Westmead, among many others. Not surprisingly, this information gathering process yielded widely differing approaches. From we steer clear of commercial products and use TDS infusions from Hunter, New England, and larger and more technical OPAT services would do that, to we use 24-hour infusers because Company A offers that, and smaller, more HITH-based services would do that, which clearly reflects services that are more reliant, with less technical expertise, more reliant on what's on offer. In May 2018, Company A follows Company B's lead from February and discontinues the meropenem infusers. At least we now have harmony for this drug, although meropenem infusers remain widely used in CF centers, as Tony has pointed out. Also in May 2018, Company B conducts a webinar on internal product evaluation processes, which I thought was a very good thing to do. But there are distractions. EMETs are coming to hospitals in our LHD, and I go into hiding for about a couple of months. And it's not until September 2018 that I actually write a please explain letter to Company A. At this point, we are caring for another 2 inter-LHD patients who would have received 24-hour ceftazidime infusers in the referring LHD, but were converted to twice-daily ceftazidime infusers on referral to our service, simply because they were residing in our district. So still the treatment by postcode conundrum. This article by Bourget, which has been cited ad nauseum today already, offers the background. Again, like the 2002 Vianney article, it refers to the mysterious 1.1 milligram per mil maximum pyridine content of the USB monograph, but it also lists a 0.3 and 0.4 ceiling for pyridine in ceftazidime as with carbonate and arginine respectively. So here are the main points of the please explain letter. I cannot find that 1.1 milligram per mil pyridine that's cited in both the Vianney article and the Bourget article in the USB monograph. I've already checked with John, and he said he took that from the articles. Tony, have you seen that in the USB monograph? No, good. That reassures me, because as far as I know, it's not in the current USB monograph. So we are all citing, and my suspicion is the article from 2014, the Bourget article, is actually citing the 2002 article from Vianney. We are perpetuating information that must have dropped out of that USB monograph some 20 years ago. So has the USB monograph been updated? I have not been able to find that out. But logically, that calculation also does not make sense. So if I put my 6-gram ceftazidime dose in a 100 ml bag and infuse it, then I'm allowed to have 1.1 milligram per ml, that's 110 milligram pyridine. If I put it in a 240 milliliter infuser, I'm allowed to have 264 milligrams pyridine. And if I put it in a 500 ml bag, I can have 550 milligrams pyridine. So the pyridine ceiling is totally dependent on the volume of the infusion, not on the dose of the ceftazidime. Makes no logical sense to me. I'm not sure what you think about that, but I just can't get the sense of that 264 milligrams that gets bandied around all the time. So if you, on the other hand, you use that 0.3 and 0.4% cutoff, that would equate to 18 and 24 milligrams of pyridine respectively for the 6-gram dose, which is considerably less than 264 milligrams. Company A stated in the June 2017 notification 8 days at fridge temperature and then 24 hours at 25 gives them under 1% of pyridine, which is 60 milligrams. That 60 milligrams is still considerably more than the 18 and 24 that I could find in the USB monograph. Extrapolating from the Bourget article, which, as Tony pointed out, uses much higher doses than we would be using, 12 grams per 24 hours. We're using the 6 grams. So we would be getting, as it's linear, we would probably get half that. So if we were using BD, ceftazidime infusers, our patients would be exposed to about 15 milligrams of pyridine, staying well below the USB cutoff. If we were using 24-hour infusers, they would be exposed to something like 46 milligrams going above the USB cutoff. My question to Company A, should you be offering 24-hour ceftazidime infusion devices if you purely want to go by the letter of the USB? Company A promises another study which would take 3 months. Then in December last year, we get this notification. 2 days, so that's 1 day in the fridge and 1 day at room temperature gives you 0.47% pyridine, and 2.5 days, that's 2 days in the fridge and 12 hours at room temperature gives you 0.41% pyridine. No reference to the 1 milligram per ml USP cutoff anymore. That's dropped out completely. Instead, we're now referring to a British Pharmacopoeia 0.5% cutoff. Just quietly. We're not actually mentioning that we're changing the parameters here. It just happens quietly. And the explanation is following assessment of stability study results. Well, the only thing that's actually changed is that they've dropped this 1 milligram per ml calculation. So since these expiries don't get us through a normal weekend, as a service, as a very obedient HITH service, not nearly as adventurous as Tony or John, we try to stick within the legal rules and we load 3-gram infusers twice a day ourselves. Then, in January, the next notification, another change. At this point, we decide to politely ignore this and just keep doing what we're doing. Back to Mrs. JH. Mrs. JH is treated in the HITH clinic with a test dose, and then the first infuser is connected. Her arm is red from the repeated PIC insertion attempts, but the PIC line has been cleared for use. Overnight, Mrs. JH presents to ED with a sore arm which she cannot bend. She is reviewed, a clot is excluded, the inflammation settles, and Mrs. JH has completed her planned treatment uneventfully today. In summary, Company A may not have checked the original sources, the USB Monograph, but relied on information published in earlier articles. Company A may have interpreted those references incorrectly. Company A may have only evaluated its products, or has only evaluated its products following a practice change by Company B, and or when specifically asked to do so by customers. For both meropenem and ceftazidime, Company A did not explain the changes appropriately. What changed between the assessment in June 2017 and December 18? There were no new publications. Is this an admission that the company cannot reproduce in 2018 the literature reviews and lab data they based their 2017 decision on? Is there actually an ongoing quality assurance process in place in Company A, or is quality assurance only triggered by the market and customer questions? Does Company A have a quality assurance dossier for its products? No public regulator will ask Company A those questions because it's not a TGA-approved product. So, and from what I've gathered in the information gathering process, HITH clinicians are often not aware that they are actually not TGA-approved products, those infusers, because they're commercially available. They're kind of in between. They're not extemporaneously compounded products. They're a standard range, but they're not TGA-approved. HITH services have to rely on company-supplied data, but do not have the capacity to verify those data. So, lessons and questions. Let's push the first point down to the next slide. All the other points are actually one big message. HITH services need quality assurance processes to verify information supplied by industry. Having such a strong HITH representation from New South Wales here today is actually a clear indication to me that we as a sector, we are striving for evidence-based practice. We want that, but it's very hard for us to do. We haven't got the resources, the skills, the technical capabilities required to individually provide quality assurance on a HITH service level. Pharmacists in HITH services can contribute by at least asking the right questions. HITH services can maybe pool resources for national QA endorsement scheme. There are other suppliers apart from Company A and B. There's another one in Brisbane, but there aren't many, and it would be a manageable task to endorse products that are commercially available. So how do other systems work with that? And I'm very grateful to Mark for the explanations of the UK, because you will see here is your yellow cover document. And that sets out the rationale. The National Patient Safety Agency has recommended that the supply of ready-to-administer products for high-risk injectables rather than aseptic preparation in clinical areas. So they want us to buy the products from industry. But they also acknowledge that in order to do so, we need to achieve goals in practice, that we need to have robust stability data. The purpose of this document is it is expected that the principles of this protocol are used when the validity of published stability data or commercially supplied stability data needs to be assessed. Compliance with this protocol should also be sought from compounded product suppliers when products are outsourced, which is exactly the situation we are in. And we're not doing that. I'm on the tender committee for our district, and as part of the tendering process, we do not assess each product that we tender for. It's beyond the capability. So one of the principles listed in the Yellow Book is published stability data may be of limited value because of inappropriate or inadequate analytical methodology, limited study duration, or improper processing of analytical data. And in the NHS contracting process, and Mark can elaborate on that in the panel discussion, it's actually built in that in the tender process, they go back, they have somebody to talk to. Industry has somebody to talk to. At the moment, there is nobody to talk to on our end. So, 2 more messages. What's the role of the therapeutic guidelines? I'm very glad to have the therapeutic guidelines here today. The HITH community needs a simple, clear, endorsed national reference. But should a reference, which is only updated every 5 years, include storage, stability, and expiry data? With the therapeutic guidelines now in 2019 still lists meropenem as BD infusers. No commercial suppliers offers meropenem as BD infusers anymore, but other services like Tony's offer 24-hour meropenem infusers. And I'm not saying that one is right or the other is right. I'm just saying, what is there a place for the therapeutic guidelines to actually go into that level of detail? Ceftazidime is required in HITH for a small patient group, and previous speakers have pointed that out. We do need ceftazidime. It's very hard for us to part with ceftazidime. What is the clinical significance of the pyridine issue? I'm not answering that question at all. I'm only observing what's out there. And does cefepime require equal assessment? So there is your cefepime with the N-methylpyrrolidine C3 side chain, and there is your ceftazidime with the pyridine side chain. They're actually in the same boat, except that N-methylpyrrolidine doesn't have the same toxicology data that pyridine has. We are now diverting our patients that we would have, or potentially, that we would have previously treated with ceftazidime to cefepime, a broader spectrum antibiotic, and that we want to reserve simply because it is more stable, because it does get 15 days from the commercial suppliers. It's not in the ETG table, and people just haven't checked for the toxicity of the side chain of the N-methylpyrrolidine. It does have a limit, the European pharmacopoeia, 0.5% of N-methylpyrrolidine, the same limit as the pyridine. But actually, I have a feeling the manufacturers haven't tested it. I've only asked company B yesterday, so I haven't got an answer yet whether they've actually checked, but I'll be interested to get that information back. Certainly questions that are still open on that one. Thank you for your time.